Hello, this is Natalia Schreier. I am presenting for Transition to Practice MN605 for Dr. Heather Weber. Um, Today I'm presenting a patient that came into the neurology office where I'm doing my clinical rotation. She's a 76 female patient coming into the office with her daughter. She's reporting history of memory loss for about 2 years since her husband passed away. She thinks the symptoms probably were there before, but feeling more aggravated now and more noticeable. History of present illness, memory loss began around the time of her husband's death 2 years ago. Location not applicable. Duration ongoing approximately for 2 years. Character, progressive memory loss. Aggravating factors non-specifically noted. Alleviating factors non-specifically noted. Timing consistent with memory issues without significant fluctuations. Severity significant enough to cause concerns of Alzheimer's disease, though she is still able to live independently at home. Past medical history of hypertension. She's taking lisinopril and is managed by her primary care doctors. Review of systems, constitutional, no fever, weight loss, or fatigue. Neurological, she has memory loss, but she doesn't have any other complaints neurologically wise. Cardiovascular, history of hypertension, no chest pain or palpitations. Psychiatric, depression or anxiety were denied. She only reports feeling forgetful. Vital signs, 130/80, heart rate of 72, respiration rate of 16, temperature of 98.6. On her neurological exam, patient generally is alert and oriented to person, place, and time. Cranial nerves were intact. Motor, we notice a slight weakness to the left leg in comparison to the right leg. Reflexes were normal, but sensation-wise, she also reported significant sensational deficit to the left leg in comparison to the right. The primary diagnosis will be suspicion of Alzheimer's disease, and we also have suspicions for peripheral neuropathy. Differential diagnosis, we have vascular dementia, mild cognitive impairment, and vitamin B12 deficiency. Additional findings for peripheral neuropathy, so we're gonna rule out that as well. At the office, we are gonna run the MMSE with a score of 25, significant enough for us to pursue the concerns of for Alzheimer's disease. For blood tests, we're gonna do a CMP, CBC, TSH, free T4, B12 levels, folate levels, homocysteine levels. We're going to do AD detect, which is a biomarker for Alzheimer's disease, blood glucose levels. We're going to do lipid panels to assess for vascular risk factors. We're going to do a polypoprotein E or APOE genotype, which is associated with Alzheimer's disease. We're going to do the beta amyloid 40/40 ratio, and we're going to do tau and phosphorylated tau protein levels. We're going to order a CT scan of the head without contrast, and we're going to order amyloid PET scan to rule out Alzheimer's disease. Additionally, we're going to order nerve conduction studies to the left lower extremities to rule out the peripheral neuropathy for the weakness and sensation deficit to the leg. Our plan will be to further to await for the results of the CT amyloid PET scan and blood work. And the nerve conduction studies. Consultations not needed because she's already at the neurology office. No medications were given at this time. We're going to wait until results come back. Patient education, we're going to discuss the importance of routine follow-ups and monitor cognitive function. We educated the patient and her daughter about the potential signs of progression and safety concerns. Patient will follow up to the office in 3 weeks after completing her labs and blood test, not her labs and her imaging, and so we can discuss further management at that point.